Good evening, everyone. A warm welcome to today's session of the Lung Transplant webinar series brought to you by the Chest Council of India. And we are delighted to have you all join us for an in-depth and clinically rich discussion on one of the most crucial components of transplant care, the immediate and long-term follow-up of post-lung transplant patients. Before we begin, we would like to take a moment to express our gratitude to the founders of the Chest Council of India for their tremendous vision in creating a national platform committed to advancing respiratory and transplant education, and to the organizing committee and the webinar committee for curating high-impact academic series, and to our course directors whose dedication have consistently elevated the transplant education in the country. I know we don't need any introduction to any of the names of these people because they are the founders of many things in our country. So today we have our esteemed panelists, Dr. Belal bin Asif, who is a surgeon from Gurugram, Dr. Gaurav Gupta from Indore, Dr. Shyam Krishnan from Kolkata, Dr. Soumitra Sinha from Chennai, and Dr. Mallikarjun from Bangalore. So as a part of the regular CCI webinar series, we first begin to start the session with two excellent talks. The first talk will be by Dr. Gaurav on long-term complications of triple immunosuppression, followed by Dr. Soumitra's talk on crisp overview of CLAD. Please go ahead, Dr. Gaurav.
Good evening to everyone. I'm Dr. Gaurav Gupta. I am practicing in Choitram Hospital in Indore. I would like to thank CCI to give me this opportunity to share my work, as well as Dr. Battu Chaitanya, who is moderator today, to address me. The topic which is being given to me is long-term complications of triple immunosuppression in lung transplant. And this is very important topic as per se, because first of all, whatever the immunosuppression we give, we have to make a balance of all those immunosuppressants. Otherwise, our patients may land up in multiple infections. Secondly, the complications which they may develop in due process of time may also happen, and these all things may lead to ALAD, BLAD, and CLAD. So today we are going to discuss the side effects of the immunosuppression which we give to our patients, as well as the off-late complications which they may develop. So coming one by one to every system, we will discuss in detail the complications of all these immunosuppressants. Infection complication, we all know that all these immunosuppressants can cause acute infections also and chronic infections also. So in all the infections, including bacterial infection, the most common infections which in long term these patients can develop are Pseudomonas, NTM infections, and MDR organism. Mind it, today whatever I will be speaking, that is taken from ERS, lung transplant monograph, chest clinics, and including the experience in Lupin, which when I saw the patient and I saw the complication which happened in them, I will include all of them. So in infectious complications, as we know that Pseudomonas, we have to give the eradication therapy also sometimes, long-term levofloxacin and tobramycin in such type of patients. And NTM also, there are a few patients which I have seen when I was in Lupin, that these patients, when they were given treatment, there are multiple drug interaction, and it's very difficult to treat NTM if they are causing invasive infections. Mind it, many a times in India, we see nowadays clinicians are treating patients with as tuberculosis, and when we do a bronchoalveolar lavage, we come to know that it's nocardia, and then when treated properly, then patients get better. So in India, specifically, nocardia is seen now a lot. So in lung transplant patients, we have to do a lavage and send it for, means you have to discuss with microbiologist and tell her that we need to see particular such sort of infections. MDR organism, they are viral infections which are specifically CMV and Epstein-Barr virus. We all know that it can lead to post-transplant lymphoproliferative disorder. Then respiratory syncytial virus, influenza, and other community-acquired respiratory viruses. Then fungal infections, obviously we all are frightened of fungal infections in our patient. Mostly the graft problem which happens with Aspergillus, it can cause the necrosis and inflammation and dehiscence of the wound. Then anastomosis, and then candida and pneumocystis is also a big problem. And because of that, we need to give in prophylaxis, we continue with the Ceftriaxone once or twice a week for long in such type of patients. And chronic airway infections lead, we all know chronic, as I said, infections as well as inflammation that can lead to CLAD. So that is very important to differentiate. It is very important to differentiate between acute rejection versus infections, because then the treatment is totally different. For infection, you have to treat with antibiotic, while if there are acute rejection, then you have to give high doses of immunosuppressant, along with sometimes you have to give induction with ATG, or we have to give rituximab. So in such conditions, it is very important to differentiate between the infection and acute rejections. Coming to malignancy, means some like seniors were asking that we have to focus mostly on malignancy because mind it, it is the second most common cause of death in post-transplant patients who survive more than 5 years. So the first common cause of post-transplant long-term complication deaths is CLAD, and second is malignancy. So it is very common. And when I was in LUN, mostly the patients, means around 60 to 70% patients, they were more than 10 to 15 years survival patients. So in such patients, we used to see this type of complications like malignancy or the development of CLAD. And so that is very important. We see whenever, means as the survival is increasing in India also, we need to address such problems which needs to be in surveillance programs, and we need to do proper screening for cancers also. So the most common is skin cancer, but the post-transplant lymphoproliferative disorder, this is also very common, and it occurs mostly in age group 45 to 62, and it is divided into, maybe it can happen in first year also, and then maybe in 5 to 15 years period it can happen post-transplant. So if it is first year, that is related to early PTLD, which is B lymphocyte related, and that is mostly because of the induction therapies which we give. And late PTLD, that happens between 5 to 15 years. It is often EBV driven, we all know, and it is related to T lymphocyte and natural killer cells. So whenever these type of patients comes to us, even if a patient comes to us and they have early onset of cough, they present with UTI and sepsis, they come with CNS involvement, stroke-like presentation can be there. There can be GI symptoms, likely nausea, vomiting, dysphagia. They can have diarrhea and bleeding. In such all such patients, first you should do a screening. You should rule out infection, but you should also search for these malignancies. So whenever these type of patients come, you do a CT chest and if required CT abdomen also, and you see that if there are ground glassing and there are diffusely spread nodules. So what I have learned in due process of time is two things needs to be addressed. If you have diarrhea as well as lung involvement, so you have to rule out the malignancy first, and then second is CMV infections are very common, which can cause all these things like neurological involvement along with diarrhea. So in Leuven, they used to do the endoscopies and colonoscopy and take a biopsy and send it for CMV stains, because sometimes you won't find CMV anywhere, even in the blood, but there will be CMV in the intestine and that will be causing diarrhea. But the problem is that even anti-proliferative drugs like MMF, they can cause a lot of diarrhea. So what they do is initially they will rule out the infection. They will send a stool sample. If infection is not there, they will reduce the dose of MMF. If still diarrhea is persistent, then they will go for a colonoscopy or CT abdomen and look for if any malignancy or any colonic carcinoma is present. So CT chest is very important. Then if it will present with diffusely spread nodules with a bit of ground glassing, and if you take a biopsy from there, you can prove it is a PTLD. So the main treatment is means from wherever you find the symptom is there, you can take a sample and send it for histopathology. The main treatment for this is reduction of immunosuppression as well as IV rituximab. 2 to 3 cycles generally patient respond. But if at all after these things, reduction of immunosuppression and rituximab, patient doesn't respond, then we can give R-CHOP regimen. We can try R-CHOP regimen. Then other cancer, which I said that most common cancer is skin cancer, which is squamous cell carcinoma. Around 50 times increased potential for squamous cell carcinoma in comparison to normal patients. Post-transplant patient can have squamous cell carcinoma, basal cell carcinoma, and less common is melanoma. So, and whenever the second reason is prolonged antifungal, it can also lead to increased risk of squamous cell carcinoma. So, alone transplant is the risk, and with combined immunosuppression, antifungal also, if patient is developing infection and fungal infections again and again, and we are giving prolonged courses of antifungal regimens, then patients are more prone for developing squamous cell carcinoma, and they should be screened. If a patient says that I have burning sensation in the skin or some lesion on the skin, it should be looked for. It should be sent for biopsy as and when required. And prevention, as we all know, a sunscreen should be applied and skin should be adequately covered. Mostly in these type of cancers we are seen in Europe when I was there, because those they are increased exposure to ultraviolet rays, and because of that they are more at risk for developing cancers. And then again, the treatment is excision followed by chemoradiotherapy if required. Topical agents like 5-FU and systemic retinoids, they can be used as adjuvant along with the chemoradiotherapy. So skin cancers are very common in Europe post-transplant. Then post-transplant PTLD is common. Then other cancer like solid organ cancers, lung, kidney, liver, colon, and cervical cancer can also happen. So why all these cancers are happening? Because immunosuppression, obviously it reduces our immunity, which is a tumor surveillance thing. It reduces that immunity, and because of that, the cancer cells start proliferating. So lung cancer, mostly, if we say about lung cancer mostly happens in patient with single lung transplant rather than double lung transplant. And so the non-transplanted lung, it can develop lung cancer. Then pre-transplant smoker, if a patient was smoker more than 20 pack years pre-transplant, they are more at risk of developing cancer, and that risk increases in the post-transplant patient. Mostly these type of cancer are squamous cell carcinoma, and treatment, you all know, there is thorough surveillance of these type of patient, post-transplant patient. We do CT scan, means the Lupin program, it do the CT in 1, 3, 6, 12 months, then 6 monthly for next year, and then yearly. So obviously, means if there is even any signs of ACR, any sign of ground glassing or early clad, it can be because to catch that type of phenomena, we do a CT scan, a regular CT scan, and that if we see any nodule or any other early SPN, then we can do take a biopsy from there, and we can do early resection also, and that helps in prolonged survival of that patient. Colon carcinoma also I've seen a lot in Leuven, because these they have a lot of cystic fibrosis patients, because in Europe cystic fibrosis is still common rather than in our countries, and that is why, and they have more than 30-40 years survival of cystic fibrosis patients. So these patients, because of CFTR mutation, they are more prone to develop colon carcinoma. So in such type of patient, they do 5 yearly surveillance colonoscopy, and if polyps are present, they fulgurate it with means they fulgurate it locally by ablation, and if required, if polyps are present, then every 3 yearly screening is done. Follow-up screening is done. But if it was CIN, then every 6 monthly the follow-up is done with colonoscopy. So these are the common types of malignancy which can happen in such type of patients. Then infectious complications we already discussed. Next is renal dysfunction. We all know that CNIs are very notorious to cause acute kidney injury followed by chronic kidney disease. And if a patient is more than 5 years survival, then SRTR report says that if at 1 year around 6.2% patients may require renal replacement therapy. Their creat may raise to more than 2.5 milligram per deciliter. And at 5 years, around mostly or at around 17 to 18%, around 20% patient may develop acute kidney injury followed by CKD. So balancing of CNIs and post-operative hypertension, patient says that they have low urine output or the creat is rising. We need to increase the water intake. We need to reduce the dose of CNIs. And I always remember that my teacher, Professor Robin Mose, he always used to see the EGFR and say patient to increase the intake of water. He used to reduce the doses of tacrolimus. And post-operative hypertension generally needs to be addressed vigorously so that patient doesn't land up in AKI. mTOR inhibitors also should be if a patient is on mTOR inhibitor, they should avoid. It should be avoided in CKD 4 and 5. So recently, one of my patient, he was very interesting patient. The transplant was done pre-transplant. She was okay urinary wise, but she started having a proteinuria post-transplant. So multiple albumins were given, and around 1 year it was like this only. Then her creat started rising. Then a kidney biopsy was done. Earlier it was thought that it is because of drugs, but when kidney biopsy was done, it came out to be amyloidosis because of the pre-transplant diseases like bronchiectasis. She might have developed amyloidosis, and because of the drugs which were given to her for immunosuppressant, she landed up in CKD. So that is very important. Proper surveillance should always be done in such type of patient. Electrolyte disturbances like hyperkalemia, hypomagnesium, and hyponatremia can happen, specifically if a patient is on ACE inhibitor. That is why it is not preferred in post-transplant patient. Generally, the drugs which are preferred are diuretics or CCBs or beta blockers. Hypertension can occur due to vasoconstriction and progressive renal failure, possibly requiring dialysis. Then coming to next, that is metabolic complications. Post-transplant diabetes mellitus is very common, and that happens with two drugs, that is tacrolimus and steroid. It happens in 19% of patients in 1 year, and 33%, almost 33 to 50% of patients may require hypoglycemic drugs in 5-year duration. Initially, obviously, insulin is given, and later on, patient can be shifted to oral hypoglycemics. Sometimes, if a patient is obese, then in such type of patient, we may require semaglutide and teriparatide also in obese PTDM. So it will help in reducing the weight as well as managing the diabetes. Teriparatide is Monjaro, which is in India also, which is being used very commonly nowadays. Dyslipidemia can increase cardiovascular risk, which is more than 50% at 5-year risk are there. So that is why statin needs to be given. It is being given in Leuven program for lifelong also. Osteoporosis and osteopenia can also happen, which is mostly CNI related. Bone resorption, antimetabolites is safer in such type of patient and can be increased, and dose of CNI should be reduced. Treatment with calcium and vitamin D, oral or IV means multiple patients who come with fracture, and then we have to reduce the dose of CNI and increase the dose of antimetabolites. oral or IV bisphosphonates can be given. Mind it, oral bisphosphonates are sometimes it is the region of GERD and which can lead to CLAD. So that is why it is always preferable to give IV bisphosphonates rather than oral. If renal dysfunction is present, then denosumab or bone anabolic agents can be given, which are these. Avascular necrosis, it can also happen steroid related, and weight gain and metabolic syndrome can also be the complication of steroids. Metallurgic effects, obviously, we all, as I said, anti-proliferative agent, it can cause leukopenia, neutropenia, macrocytic anemia, and thrombocytopenia. Also, bone marrow suppression can happen. GI side effect, as I discussed earlier, also, it is mycophenolate is very notorious to cause GI side effects. Initially, we should decrease the dose of the drug. But if at all patients are having refractory diarrhea, then sometimes we have to stop also mycophenolate, and we have to shift to something like azathioprine because it's well tolerated when diarrhea is there. GI bleeding risk is high, and once patient is off diarrhea, then we can shift back to mycophenolate. Pancreatitis is a very common side effect of steroid or azathioprine in such type of patients. Neuropsychiatric complications, there are multiple patients which I have seen more than seizures or press, which can happen with tacrolimus. Patient can have tremors, headache, and neuropathy. Patient can have anxiety, depression. More type of neuropsychiatric disorder happens with tacrolimus. So many patients, they are substituted with some other drug like cyclosporin, or sometimes they have to be given antipsychotic medications also. So steroid-induced psychosis is also common, but most often it is seen with tacrolimus, neuropsychiatric complications. Cardiovascular effects, as I said, accelerated atherosclerosis can happen. Hypertension, around 50% of patients, mind it, 50% of patients, even more than diabetes, can happen in first year after lung transplant. So most of the patients after first year post transplant, they may, or 5-year post transplant, at least they require beta blocker, CCB, or diuretics. ACE inhibitor, as I said, it will have RAS suppression, which will lead to hyperkalemia, fluid retention, birthing heart failure. So it is not recommended. And overall cardiovascular risk is increased post lung transplant with immunosuppressant. So obviously, my senior colleague will discuss about chronic lung allograft dysfunction. But generalized, I would like to tell that it is the most common cause of death in post-transplant patients who survive more than 5 years. And it is of two types: bronchiolitis obliterans syndrome, restrictive allograft syndrome, which sir will discuss. But the common cause of CLAD in which I learned during my residency in Europe is that now with recurrent infections and drug toxicity, which is the most common cause. Along with that, GERD and obesity, which in OPDs I have seen is becoming a very common cause of CLAD, and that is why in Europe the proper rehabilitation setup for post-transplant patients are being set up so that these patients doesn't go into CLAD. And obviously, the leading cause of long-term graft failure. Early means the acute cause is infection, and ACR, but the long-term cause is SCLAD. So, concluding with the last two slides, monitoring and management strategies. We should monitor with regular renal, metabolic, and metallurgic monitoring for drug levels, trough levels, and we should target with the least doses of the immunosuppressant, which will create a balance between less infections as well as the preventing the graft failure. So the least doses which can be given and the graft can survive, that should be targeted. Infection prophylaxis and vaccination should be always there. In infection prophylaxis, like they give azithromycin twice in a week and ceftriaxone twice in a week for long term. Along with the statins also they give for lifelong. But as and when required, for CMV ganciclovir and for this thing, for aspergillus infection, if it is diagnosed, then Cresemba or isavuconazole is being given for 6 to 12 weeks, and it can be prolonged to 6 months. So CMV also in CMV they do weekly CMV monitoring, and after the CMV PCR is negative, then 2 weeks after that also they continue the prophylaxis, the treatment. And vaccination, obviously live vaccine should be given prior to transplant. After that, only killed vaccine can be given. Cancer screening program should be there. As I said, that surveillance with colonoscopy, with all the blood markers should be done routinely in such type of patients. In elder patients, like in India, serum PSA should be sent. Immunosuppression dose minimization, as I said, should be possible. In surveillance tool, obviously spirometry, because the definition of the CLAD is based on spirometry. Spirometry should be done as per protocol, because every center differs with their protocol. Lab parameters should be taken care of. Radiological assessment should be there. We should have very less threshold for doing a bronchoscopy and biopsy. In early 1 year, they do central and peripheral biopsies. Then they do only peripheral biopsies till 2 years. And then as and when required, bronchoscopy is done. Nowadays, the role of cryobiopsy is increasing, but there is no standardization till now, no studies being done that what size of sample should be taken. So that is still under discussion. Biomarkers like donor-derived DNA, that is very important. If in Europe it is being followed, if donor-derived DNA is increased, then it is a risk for developing the rejection. Then 24-hour pH monitoring is important in such a patient who are having GERD to reduce the risk of CLAD. So in conclusion, triple immunosuppression is essential but carries significant long-term risks. Early detection and proactive management improve outcomes. Multidisciplinary, mine is the last line is very important. A multidisciplinary, there is a multidisciplinary team for everything, like for pre-transplant assessment, for post-transplant ICU care, so there is a MDD team for everything, and it always helps. Their teamwork always help rather than going alone. Ekla chalore is not possible in lung transplant. So always a multidisciplinary team should be there from pre to post transplant and lifelong also. We may need our colleagues like GI people, kidney, nephro people, and all those. So that will lead to patient survival and quality of life. And hopefully in future, we are going to increase the survival of our patients also. And nowadays we are seeing also many of my patients who are transplanted here in India, they are now 5 years plus survival. And that is quite we are quite hopeful that that will increase further on. Thank you, the audience. Thank you to the CCI team, moderator ma'am, and audience who here patiently. I would also like to thank my team, my teachers like Professor Robin Bose and Saskia Bose, because of whom I have a bit of knowledge of lung transplant. Thank you.
Hi, good afternoon. I'm Dr. Roy. We will talk to you about a little bit of CLAD and what's its implication. And we all have gone through all the different implications of different complications of the transplant. And finally, we have come to almost nearing its end, and we'll be talking about the CLAD. So CLAD, chronic allograft dysfunction, is a long-term, slow, indolent decrease in the function of the lung allograft, which impacts the patient's quality of life, and ultimately it shortens the survival. This condition progresses from a minimally symptomatic irreversible decline. You remember that it's an irreversible decline. However, with whatever drugs we are having, though they are not much, we can only reduce the fall of this decline, but we cannot reverse it, we cannot make it better. So it's a minimally symptomatic irreversible decline to start with in the spirometry, and then finally it comes to an exertional dyspnea, and then to significant symptoms even at rest, and perhaps needing oxygen at rest also. It is a progressive disease, can also present subacutely. It can also present very subacutely, like within 1 month, more than 10% of the lung volume can come down. Then how is the total number of patients who presents with CLAD? ICLT data shows that 50% incidence of CLAD in the first 5 years, and almost 3/4 of the patients were having some kind of a CLAD after 10 years. And over 50% of the patients are reportedly dying primarily due to the CLAD. So it's a very difficult problem to handle with, other than the infection and cancer, which are the principal long-term cause of the death after the transplant. So what's the actual definition? Definition is decline in the lung function from baseline, FEV1 decline more than 20%, that persists for more than 3 weeks. So what is the baseline? How do you come to? We take 3 best values and we take a mean of that. So that becomes the baseline. So anytime if the FEV1 values decline more than 20% and persisting for more than 3 weeks, starting after 3 months of post-transplant with no other identifiable causes. Now, what are the other possible identifiable causes of chronic lung function decline? They could be surgical factors like the lobectomy. So you cannot get that whole 100% kind of lung function. There can be chest wall surgery or phrenic nerve damage. There can be single lung transplant. There can be mechanical factors like persistent pleural effusion, airway stenosis, weight gain. Patient was very thin at the beginning after transplant, then started gaining weight, maybe because of the food habit changes, maybe he feels better, maybe because of the steroids. There can be myopathy, there can be persistent edema from any cause. There can be localized infections or scarring. There can be underlying transplant problems, which was previously there, like the LAM or sarcoidosis, which has now become recurrent disease in the lung. There can be drug toxicity, tumor infiltration, etc., etc. So many things. So these are the different other things you must run through in your mind before saying that yes, we are having a CLAD. So this CLAD name, how it was coined? It was coined perhaps first in 2010 to cover everything together. But then slowly we found out it was previously called BOS, bronchial obstructive syndrome. So we have found out that not everything is BOS in CLAD. And so over next 10 years, slowly it has evolved and it has differentiating two things. One, it has differentiated the reversible causes of graft dysfunction. That is very important. The reversible causes has to be excluded. And also it has emphasized within this 10 years slowly over time that there is also a restrictive function. Not everything is obstructive function like BOS. And there will be some about 20 to 25% of the patient of CLAD will be having a restrictive phenotype. So these two things have been defined slowly over time. And then we have now the whole umbrella of the CLAD. Okay. So what are the phenotypes we just talked about? One is the BOS, that is obstructive ventilatory defect. On the PFT, FEV1 by FVC ratio will be less than 70%. Secondary to a concentric obliterative fibrosis of the small airway, the distal small airways having a concentric obliterative fibrosis. And that is about 75% of the cases of the CLAD, 70 to 75. RAS, the restrictive pattern, will be persistent subpleural predominantly fibrosis, mostly involving the upper lobe with a pleuroparenchymal fibroelastosis picture. There can be bronchiectasis, there can be GGOs, there can be reticular parenchymal changes, multilobar opacities. There will be restrictive pattern in the PFT. So along with that obstructive area, the FEV1 decline is needed as per the definition we have talked about, more than 20%. Along with that, there has to be a TLC also reduction more than 10%. So more than 20% of FEV1 reduction plus a total lung capacity decline of more than 10% is coming for RAS. CT will be showing as non-resolving subpleural and perilobular consolidation. Will show you the pictures with or without an obstructive, with an OP picture, with a GGO picture, septal thickening, etc. can come up. Then there will be a mixed pattern with both obstructive feature of small airway changes, of airway, there will be the small airway changes of the CT will be looking more blackish. Along with that, there will be all these restrictive changes, GGOs, some fibrotic changes. There can be pleuroparenchymal fibroelastosis changes. Everything together, it can be there. So that is a mixed. One part of it, one subset of the BOS will be ARAT, that is azithromycin sensitive one. Azithromycin sensitive airway disease will be a pro-inflammatory profile in the lung. It will be always having a neutrophil percentage more than 15% of the BAL without any evidence of infection. So this is important, that 15% more of neutrophil in the BAL is important. But the problem area is this will slowly get better. Maybe about 10 to 15% of the FEV1 will be improved with this 40% of the patient who are having suspected BOS, but they respond to azithromycin. But currently, almost everybody, every patient of lung transplant will be on azithromycin, thinking about that this can be beneficial. Even it can perhaps we start nowadays before even the CLAD BOS kind of picture sets in, to prevent or even to postpone. If we start nowadays between 3 months to 1 year, sometime within that post-transplant we started. So nowadays it is very difficult to differentiate or diagnose that whether this is an pro-inflammatory azithromycin sensitive airway disease or not. But that is an entity which improves somewhat with azithromycin. So with this, how does it look like? Again, just like the BOS, there will be bronchial wall thickening, there will be mosaic perfusion, and there will be the expiratory air trapping will be always there with the BOS kind of picture. That is a hallmark, you can say. The BOS pictures, the expiratory air trapping will be the hallmark on the CT image. Now, the severity. There are different stages. So the first stage is FEV1 more than 80% of the baseline, but it has fallen from the maximum baseline which is available for the patient previously. More than 20% decline has happened, but his or her FEV1 is still more than 80%. So then after each and every step, there will be a fall of 15%. FEV1 between 65 to 80%. Stage 1, stage 2 will be 50 to 65%. Stage 3 will be 35 to 50%. And stage 4, the severest form, will be less than 35% of the baseline. And As expected, a decrease in lung function from each stage, from stage 0 to stage 1, and then onwards for each stage as you go down, there will be a threefold increase in mortality with each kind of loss of FEV1 stages. Okay, so that's why the severity and this staging is important. So what are the risk factors, and so how to treat? Before that, as you understand that there is perhaps not much in our armamentarium, so we have to tackle and avoid the risk factors, and perhaps be very careful that those are the causes and they should not be coming up, kind of thing. So currently the thought is that this is an allograft tissue remodeling as a response to a multiple internal and external stimuli, and there can be the pre-existent conditions and then the post-transplant immunological and non-immunological, whatever the insults are coming up, has been associated with this increased risk of CLAD. So what are the pre-transplant matter? Pre-transplant matter, the most important remaining that the HLA antibodies, and that is the antibody-mediated acute rejection will beget slowly over time the CLAD. The severity of the antibody or the severity of the antibody rejection, or how persistent your acute rejection is, will depend how quickly your CLAD or how difficult your CLAD will set in. A DSA, if you are having a DSA detection, is an early predictor for a CLAD later on. So there are situations when the patient is having no clinical or even histopathological changes in biopsy for rejection, acute rejection. But if there is DSA and you treat those DSAs with ZIL and therapy, and it has been shown that the development of the CLAD has been postponed. So that is the important thing. DSA is detrimental towards having a good lung function or involvement of CLAD later. So that is one thing. Also, it has been shown that the frequency and the severity of the acute cell rejection what you are having are also directly correlated with the risk of developing CLAD later. So this is one part. Next is the very important again is GERD. This GERD is a problem before transplant also and post transplant. So that's why we focus so much for GERD before the transplant. Chronic aspiration is linked to increased pro-inflammatory cytokine, recruitment of the alveolar inflammatory cells, and the reduction of the surfactant proteins and antiproteolytic mechanisms. So you must put effort towards managing the GERD thoroughly. Other than that, infections, the CMV. CMV is the most important well-known cause and driver of a progression of the CLAD, acute and chronic rejection, and also of lung function. So CMV in the blood is important. Remember that CMV in the blood is important. CMV in the Belal sample perhaps is not an indicator of CLAD happening. So this CMV virus actually is acting more as an activator of the immunological system rather than as a direct trigger of the chronic rejection process happening. So that is important differentiator you must remember. Other than that, what are the other viruses? Adenovirus, parainfluenza virus, which affects the lung, RSV, human metapneumovirus, all these are important. COVID-19, perhaps we have seen slowly improve, the lung function slowly improve. It does not cause as much as CLAD formation later on. Bacteria, Staph aureus infection and Pseudomonas infection. Not only that, the colonization of those are also important to cause CLAD. So not only a bacterial infection per se, but a colonization is important. Same wise, the fungal Aspergillus, not only an invasive Aspergillus infection, but also the colonization is very important. And that's why we give all these drugs, Septran and other drugs to cover Aspergillus for 3 to 6 months post-transplant. Septran will be continued perhaps lifelong. And the PGD. PGD is again another dreaded problem which has to be tackled. So it's a PGD, the inflammatory process during the severe PGD, trying this adaptive immune response against the allograft, and slowly it begets the CLAD. So as severe your PGD, the severe or earlier or quicker will be your CLAD is. So other pre-transplant conditions, if the patient is having an IPF and CF, these two conditions, if you are doing transplant, perhaps they are having more predilection towards CLAD formation later. An obese person with a BMI more than 30 will be having a predilection towards more PGD formation and subsequently a CLAD formation. Lungs taken from a smoking donor, high oxygen concentration of more than 40% FiO2 and the tidal volume more than 8 ml during the lung reperfusion is also associated with greater severity of the PGD and as a consequence, the increased risk of the CLAD happening later on. So what's the natural history? So we have now learned the risk factor, the causes, and now we will talk about the how does it progress. The RAS phenotype has the worst survival rate, perhaps 1.5 years. BOS grade is associated, as we have discussed, the BOS grade is associated with mortality. Hence, the grading of the BOS is important. Median survival after BOS is perhaps 3 to 5 years, somewhat better. Monitoring the lung volume in patients with BOS will identify the patients with a significant hyperinflation. The RV-TLC ratio more than 50 is an important criteria which you should look for, and that is also a sign of early mortality. Early identification. So with all those things, the early identification treatment of the acute rejection, if it is happening early, controlling the risk factor, which we discussed just now previously, mainly the GERD, the infections, the PGD, and the pre-transplant conditions, the DSS, these are important risk factors to control using the infectious prophylaxis, both bacterial and fungal, and interventions such as azithromycin, which almost now everybody is getting, and start them early, start azithromycin early, maybe 6 months, maybe by 1 year, definitely. These strategies will prolong the clad-free time and the survival after transplant. So how to prevent clad? Those things we said. BMI, maintain a healthy BMI, more than 30 is not good. Monitor and treat aggressively GERD, aggressive GERD management before transplant, post-transplant. The acid suppression therapy has to be very good. There has to be prokinetic. Even after acid suppression therapy and prokinetic, if you find that GERD is persisting, you must consider fundoplication very early. If you do, there are studies which have shown that fundoplication done 6 months after transplant in a case of a severe GERD will make your chance of having clad double. So if there is a need of GERD persisting after acid suppression therapy and prokinetic, do the surgery at the earliest, maybe within 3 months post-transplant. It will be a sweet spot to do the fundoplication surgery, and perhaps also endoscopic gastric myotomy. The surgeon will decide upon that. Then early diagnosis of rejection. As I said, early diagnosis of rejection. Treat the DSA, even in asymptomatic patients. Perhaps treating the DSA will be good for you to finally postponing the clad. Asymptomatic loss of lung function has to be picked up. So that's why the importance of serial PFT comes after transplant. A baseline CT thorax, maybe at around 3 to 6 months post-transplant will be your baseline, and you can make out the changes whenever there is a more than 10% drop in lung function. Transbronchial lung biopsy, not much important, very low yield. Changes like OP and bronchial eosinophilia might suggest a clad. Your ACR and AMR are the known risk factors. So circulating DSA, we have discussed about that, has to be tackled. DDCFDA monitoring to pick up early rejections in asymptomatic individual is also important in a specific kind of patients. So the first line of defense against clad is protect the patient from the known risk factors and perhaps look for early changes and to start aggressive therapy for that. So the treatment is, the first line of treatment is optimize the maintenance immunosuppression. You now know that perhaps cyclosporine is not so good, azathioprine is not so good. Perhaps the other drugs, which is now almost universal. People are perhaps now not using those two drugs. So other than that, there is perhaps not much optimization is possible. So MMF and TAC should be there within your treatment regimen. Treat the acute rejections aggressively, vigorously. Manage and prevent PGD. As difficult your PGD is, your clad will be much sooner. Azithromycin, fantastic drug. Perhaps we don't have much armamentarium, but one of the best drug is perhaps azithromycin, which will decrease the level of IL-8, and that is a mediator for the pathogenesis towards the clad. When to start? Also, azithromycin improves the esophageal motility and the gastric emptying. So when to start? As early as possible. Maybe 3 months, maybe 6 months, maybe before 1 year will be better, even if there is no clad is happening. Montelukast, perhaps we are much enthusiastic about Montelukast, but perhaps not much evidence is there. Montelukast has been shown to improve the pulmonary function in patients who has developed obliterative bronchiolitis. So picture after a GVHD in bone marrow transplant patients. But we are just bringing it out here to see if it works. Few papers suggest that Montelukast might work, but whatever, it does not cause at least any harm. We can always utilize Montelukast. The lymphocyte depleting drugs like alemtuzumab, be very careful about alemtuzumab. It is a very prolonged acting one, and your infection chances will become much more. Carfilzomab, some centers have started using it, carfilzomab along with that. And then the TNF alpha inhibitors are there. One promising thing is JAK inhibitors. Perhaps JAK inhibitors are an important promising thing. We have to look into the future, whether it will be working good or not. It prevents the immune cell activity, airway injury pattern, and the cytokine blockade, and could be a good drug in the future. But at this present moment, the best thing what is available with us is the extracorporeal photopheresis. That ECP is the best among all for treatment towards CLAD at this present moment. So how does it work? It removes the activated lymphocytes through leucopheresis. So what it happens, we take out from the central line and the blood, and through this leucopheresis apheresis process, we separate the components, and then we treat these WBCs with a drug called methoxysoralen, and which will be now, then we add heparin and saline, and then it is been exposed to ultraviolet light, and it will be activated, and thus it is expected that it will reduce the CD4 cells completely or almost completely, and that's how the lung function decline can be, if not arrested, at least the slowing can be done. Lung function decline can be slowed. Followed up studies of patients treated with ECP for ACR have shown the improved survival, particularly in patients with the BOS phenotype without any increased risk of infection or significant adverse effect. It has been shown the ECP can be given on any stage of the BOS, and perhaps there can be some improvement, but it is best obviously in the early stages if you initiate this. Lung retransplant is a last consideration and the definite consideration in patients with end-stage CLAD. However, you remember that it is only for a very highly select group of patients, and the survival outcome are not so great even in the best centers in the world than like in initial transplant. So in conclusion, it is one of the principal cause of problem, the Achilles heel of lung transplant, I would say, that limits the lifetime of the lung allograft. So find out the risk factors, reduce them, early identification of the episodes of rejections, and the DSA also is important to identify and treat it, perhaps them already. So these are the only tools available which will decrease CLAD. New therapeutic options are needed. Maybe a JAK inhibitor will come up, maybe something else will come up later on. But at this present moment in our hand, ECP is the best available therapy other than retransplant, and we really await a great drug towards preventing CLAD. Thank you.
Welcome back. Thank you, Dr. Soumitra and Dr. Gaurav, for those insightful presentations. I know we are discussing a lot about complications of lung transplantation, but it doesn't mean that lung transplantation is the most difficult organ transplantation across all other solid organ transplants. But it doesn't mean that patients doesn't have any quality of life or anything. It's like we still do lung transplantation, and there are a lot of advances in lung transplantation down the lane. With advance of ECMO, EVLP, and better donor management, better immunosuppression, and regular follow-up and scrutiny, these people are living longer. Like as Dr. Soumitra mentioned, 50% develop CLAD, but the rest 50%, like they still don't develop CLAD, right? So I think we still have to see that positive aspect of the lung transplantation, and lot of referral doctors feel that like once the transplant is done, patient is getting a lot of complications. There is not much good quality of life. But see, when the patient is on 4 liters or 3 liters of oxygen, he is not able to walk till his restroom. Also, if he is not able to walk in the house, with transplant, we are going to give at least minimum 3 to 4 years of very good quality of life. And if we follow up these patients very early and with a strict follow-up protocols, that we can postpone the development of CLAD, we can postpone the development of RAS. And fortunately, I think in India, AMR is a bit less compared to the Western population because of uniform genetic pool we have. So at least we are able to minimize certain things, but infections are a bit more here. So I think if we balance everything, we are going to have really good outcomes with lung transplantation. So today, now we move to a panel discussion, which brings together the outstanding team. Yes, Dr. Soumitra.
Contradict you slightly before you go ahead with your questions. One, CLAD is not all or none. It is, even if it is a severe CLAD, that happens only about 10 to 15%. That 50% is all the stages together. So stage 1, stage 2, stage 3, people can still manage their life well, not very well, but perhaps well. That's one point. And second is, you said 3 to 5 years post-transplant. I would suggest broaden the horizon perhaps more, maybe 10 to 15 years also.
Yes, that's what I'm saying. Like really good quality without any complications for first 3 to 4 years, they'll really maintain well. After that, they may develop clad, but it doesn't mean that that is the end of their life. They sustain this for another 5 to 6 years. So I think approximately 7 to 10 years, they can reasonably have a good quality of life where they can fulfill all their dreams, see their kids grow, and lot many things they can do. So like
Professor used to tell from Toronto, you also say that we are not giving a gift of life to the patient. We are giving the gift of the dreams to become completed and fulfilled of all the families and for the patient.
Totally agree. So we'll for the next 1 hour, we'll discuss regarding immediate post-operative follow-up, like how we follow these patients immediately after the surgery, and what immunosuppression we'll give, and how do we monitor the immunosuppression, and how do you monitor for chronic rejection and CLAD, and what is the long-term survival of this patient. And for the long-term survivals also, these people need monitoring. So how do we follow up at each and every specific point of time, we are going to discuss. So we are going to open the panel discussion with Dr. Belal. Sir, as a transplant surgeon, what key clinical and graft-related parameters do you monitor in the immediate post-transplant period? So you are muted.
Thank you, Dr. Chaitanya. Thank you for the invitation from the CCI. A very wonderful discussion so far. And, for me, as a surgical perspective or from a surgical standpoint of view, my immediate post-transplant period is, usually about 1. That is ensuring that the graft we have implanted is perfusing well, it is ventilating well, it's healing well, and it's free from any early mechanical or anatomical complications. And therefore, when we talk about the immediate post-operative monitoring, it falls under the 4 surgical domains. So you should have good perfusion. The ventilation mechanics should be okay. You look at the airway integrity and see that there are no issues with the airway integrity. And of course, the pleural chest wall interface, which means you look at the pleural space and you want to rule out any pneumothorax, any pleural effusion, hemothorax, which could be the problem. So when we talk about the perfusion related issues, of course, hemodynamics, maintaining an arterial pressure and watching these trends. Is there a rising need of vasopressors? You do repeated bedside echocardiographies to rule out right ventricular dysfunction. And then also you keep very closely looking at the, imaging and see for any unilateral abnormalities that could indicate a surgical problem. So, usually when there is a non-surgical issue, they usually be bilateral. But in cases of unilateral, let's say opacity that is happening on unilateral side, that can indicate a surgical problem, either with the, mucus plugging or some airway issues, or even sometimes rarely, but it does happen, vascular issues. Apart from that, I think one of the most important things to look at is the airway anastomosis integrity. And that is when we look with repeated bronchoscopies and look for the mucosal color, ischemia, sloughing, dehiscence, or any suture line disruption. And of course, a close detail to the rate and the character of the chest drains that is happening. So you must rule out any recurrent effusion which is compressing upon the lung and which may affect the functioning of the graft. Any persistent pneumothorax or hemothorax which can impair graft expansion. And of course, lastly, from the surgical perspective, is the chest wall stability and bone integrity. That is very important. So we look for signs of infection, dehiscence, or lung herniation. These must be caught very early.
Yeah, thank you, Dr. Belal. I think yes. So how frequently do we monitor echo, like for the RV dysfunction, only if the span gas is showing high PA pressures or something, or will regularly monitor echo every day till the patient is out of the ventilator or ECMO?
Yeah, so in our hospital, what we're doing is, we regularly monitor every day with echo till patient is out of ventilator.
Okay. So, Dr. Gaurav, because you had a great talk on immunosuppression, there are different protocols each center follows, right? Some centers follow directly immunosuppression from day 1 tacrolimus. Some centers will delay the immunosuppression till day 4 of basiliximab. So what do you think, like when do you start maintenance immunosuppression after the induction, or like along with the induction, or which drugs do you choose initially and what you'll wait for certain time, and what are your target levels of tacrolimus and how frequently you're going to monitor those levels in the early post-operative period?
Thank you, ma'am. So for some people, as you said, it is different in different centers. But what I have observed in U1, that the just as you open the clamps, after opening of the clamps, it's day one for you, and you can start straight away start the triple immunosuppressant which we give steroid. Obviously, we have given the steroid before the induction, all before the opening of clamps. Also, 500 milligram we give, and MMF also we give prior to opening of the clamps. So just as you open the clamps, you can start adding tacrolimus and tacrolimus in that protocol, in that regimen also. So you are already on steroids and MMF, and then you add tacrolimus after opening of the clamps. So initially you will start with dose of 0.05 to 0.3 milligram per kilogram, and initial 3 months you will like to keep the TAC levels at around 13 to 15 nanogram per ml. And slowly you taper, and all these three things you tapered up till 1 to 2 years, and after 2 years you keep the minimum doses of all three immunosuppressants.
And TAC initially after the transplant, which mode like of administration you prefer? Like, is it an IV or sublingual?
So, ma'am, depend on, like, if a patient after transplant is extubated twice, or it means it is started in infusion, but as soon as the patient is extubated, started taking orally or by RT, we start giving oral tacrolimus.
Okay.
So nowadays, because every center, they are trying to extubate patients on very next day or next to next day, means second or third day patients are being extubated. So that's not an issue. Patient can be shifted to oral tacrolimus.
Yeah, agree. Because some centers, like a lot of centers, prefer to give TAC after day 4 of Besliximab because the initial hyperkalemia, initial renal dysfunction and everything they wanted to prevent. But I agree with you. Like, I think it's always better to start tacrolimus as soon as possible because to prevent the early rejections or anything, I think. And Dr. Shyam, once the patient arrives in the ICU, what are the immediate monitoring priorities? Like how frequently do you monitor ABGs and what ventilator goals? Because a lot of the time, if we don't know, we'll just treat them as normal lungs as such. So how is it different managing these patients on ventilator from a regular normal lungs, and what are the hemodynamic targets what you set for these patients? Can you unmute Dr. Shyam Krishnan? Yeah, thank you.
So very good evening to all of you. So when we basically receive a patient post-transplant, just after the surgery, I think so the vital points we need to keep in mind is obviously ensure hemodynamic stability of the patient. Take a handover from the surgeon whether he's happy with the drains, the draining. There's no, he's not suspecting any leak or a bleed there. Maintain the hemodynamics of the patient, see if he or she is requiring vasopressors. The ventilator goals would be usually to, on the lines of a lung protective ventilation, tidal volume of around 6 to 8 ml. Can even go lower, moderate PEEP. The plateau pressure should be less than 30. Look at the ABG blood gases. We look at the lactates. The lactates ideally should be low. Urine output should be good. The PO2 we usually aim for a 92% saturation, or the PO2 of around 70 to 80 millimeters of mercury. So these are the broadly the the usual parameters which we stick to. It's all to ensure primary graft dysfunction. And the other thing is these patients do not have the denervated, so they can't cough or clear secretions as such. So in the first 24 hours, we would like to do a bronchoscopy to clear out the secretions or the clots. So that's the first things which we do when we receive the patient in the ICU.
Yeah, thank you, Dr. Shyam. And Dr. Soumitra, we have started the immunosuppression and we have started the other supportive therapy, but antibiotics play a major role in the initial early post-operative period. And see, in Indian scenario, we usually start on higher antibiotics because the patients will be already in an ICU. They will already be on higher antibiotics, and we have to start a better antibiotic compared to what the donor is on. So we reasonably start on a very good antibiotic coverage, but the toxicity with the antibiotics, what we have, as we know in the Western population, they'll start with a very basic dose of piperacillin or even third generation cephalosporin. Also, they can get away with the transplant. But for us, we need to start at least minimum with meropenem. So how do you like tackle the side effects of these antimicrobials along with the immunosuppression and antivirals along with this mycophenolate? So how do you deal with these scenarios?
Very big question, indeed. Okay, so if I am getting a patient from ward or from for doing transplant, in those kind of patients, actually, we still do with the piptas only, not with meropenem or something else. Patient who is already in ICU and maybe on ECMO kind of patients, those patients will be needing, as per their recent culture, that kind of antibiotic kind of thing. So still we do, and a standard typical combination is piptas or a cefepime with the vanco or teicoplanin. And then maybe perhaps the pathway directed, whatever the patient was getting at that time at ICU, to continue that. And maybe by 48 to 72 hours, we get the donor bell report and we can direct it accordingly, whatever is there. And our new first bronchoscopic culture will be coming up in 48 to 72 hours, and we can redirect our therapy of antibiotic accordingly. Yes, it is difficult for cases where there is already a colonization, like say a patient is having bronchiectasis or a CF. There you are in a soup, really, you have to give not only injectable drugs, whatever we are having, plus a nebulized format drugs. We know all those things. There's no need to do threadbare kind of thing. But keep an eye open for the donor airway culture and whatever you are getting in first 40 to 72 hours. And accordingly, you titrate your prophylaxis or treatment antibiotic accordingly. Your next part is the other things other than the bacteria, perhaps. The first and most important, there comes the CMV. CMV prophylaxis. There is protocol guidance now everywhere. The CMV prophylaxis depends on high risk or low risk kind of thing, whether there is a mismatch or there is a low risk where both of them, the donor and recipient, both are negative, or both are positive, that will be a moderate risk, and a high risk is when there is a mismatch, either of them is positive or negative. So in a high risk cases, Valgan you must give for 6 to 12 months. Moderate risk when both are positive or the recipient is positive, you give for somewhere about 3 to 12 months. And the low risk where there are both of them are negative depends on you. You can either give preemptive therapy or a short kind of prophylaxis. That's how we do. And obviously, you have to adjust with your renal status. How does it go? And accordingly, you have to adjust your CMV prophylaxis. Then the fungal thing that you must consider with that. The highest risk of invasive aspergillosis is an important thing. So accordingly, we give our azoles, mainly voriconazole. But again, you have talked about the drug and drug things. We will talk about that. But the voriconazole need to be given for 3 to 6 months. Maybe we usually start at around the 5 to 7 days post-transplant. Before that, we give IV cover. And then if there is a problem with voriconazole, maybe the newer kind of things, newer azoles, we can give. Then PJP prophylaxis, Ceftriaxone lifelong, we must continue. If there is a problem with self-allergy or intolerant patients, there are other things like Dapsone or inhaled pentamidine around there. Then the drug-drug interactions you talked about. The most important there is the azole group. We have to give, as we discussed, around 6 months at least. So azoles are strongly inhibit the CYP group of enzymes. So there we have got problem. So voriconazole with tacro or cyclosporin, whenever there is voriconazole you are giving, you reduce the tac dose because it will increase somewhere about 50 to 60%. So we preemptively reduce tac dosage whenever we are adding voriconazole. Perhaps posaconazole has got a slightly better response. Maybe you do not need to have that much of the problems. Then your macrolides again has got a problem with CYP enzymes. Azithromycin is better. And then the last one, which you always think is the anti-TB drugs, if you need to give the rifampicin. whether it will be okay or not. Again, they are strong CYP inductors, so you should be careful about the TAC and cyclosporin. Again, here there is better is you come down on, you increase the dose of TAC and again monitor the TAC dosages and see how things are going. Or if you can replace rifampicin with some other drug, that is well and good, maybe rifabutin or rifapentine kind of things. But I prefer to continue rifampicin because one of the best drug which will go intracellularly and can treat TB. So I increase the tacrolimus dose and monitor the dosage accordingly. I think that's it, kind of thing. There will be many other drug-to-drug reactions. You have to keep your eyes open.
Yeah, thanks, Dr. Soumitra. To add, because you have added even anti-TB, which is very common in India because patients will be on TB medications, and after transplant, we need to continue that. And thanks for those insights. Dr. Mallikarjun, like as Dr. Belal has mentioned and Dr. Shyam has mentioned that we need to do bronchoscopies immediately after the transplant to assess the airway anastomosis, and because these patients are not able to cough out secretions and everything. But we have seen in Western countries that there a lot of few patients, they get away from the hospital even without a bronch after the transplant. Only during the time of transplant they do, when the anastomosis are in place, they'll check the anastomosis, and after that, only if there are any complications. So what's your take on when you have to do a bronch after the transplant, and at least in Indian scenarios, and how frequently you have to monitor till the patient gets discharged? And when we are doing bronch, what are the precautions we need to take? Because they're fresh anastomosis, right? So what are the precautions? And with the airway pressures on the ventilator, with the bronchoscopy in situ, we may induce some complications, iatrogenic. So what are the precautions we need to take while doing bronchoscopy early after the transplant? And when do you prefer doing it?
Madam, bronchoscopy becomes central to the diagnosis and management as soon as the post-transplant. Bronchoscopy, it starts in intra-procedure only once we do it to check the graft and for any primary graft dysfunction. And post that, for first 24 to 72 hours, for any secretions or atelectasis, it is done to remove. And afterwards, once in a month or any infection is suspected, and 1 month, 3 months, 6 months, and 12 months transbronchial biopsies to check for scheduled TBBs for rejection. The precautions are here, it should be done under strict sterile conditions, and we have to check the pre-oxygenation status and hemodynamic stability, and take care during the procedure to give minimal sedation, so the risk of hypoventilation will be there, and post-procedure morbidity can increase. And single-use bronchoscope to be adopted here if feasible, so that the risk of cross infections is avoided, and till the patient is in the hospital, if he needs multiple bronchoscopies, it can be utilized.
Yeah, I think we need to spend very little time at the anastomosis also. We should not spend a lot of time at the anastomosis. Do not do much suction at the anastomosis.
Careful maneuvering around and avoid large lavage volumes in the borderline lung.
So I think Dr. Gaurav, because you have been trained recently, right? So just what's their experience in doing this post-operative bronchs? Because in Toronto, the patients can go away without a bronch also after the transplant. Only if there's increase in peak pressures or difficulty in weaning from the ventilator or any X-ray opacities or anything, then a bronch will be done. Because intraoperatively after anastomosis, anyway, the bronch will check the anastomosis. So what is your take on that?
So, ma'am, what I have seen in Leuven, that they have a very low threshold for bronchoscopies as well as any type of surveillance, because they think that if there is proper surveillance, patient won't develop complications like A-LAD, B-LAD, C-LAD or something.
No, I'm just taking immediate post-operative.
So immediate post-op, yes, immediate post-op, like if a patient is extubated, they will do it at 14th day. And then after that, in first month, 3 months, 6 months, 12, that protocol they follow. So obviously, if there is no complication and patient is comfortable, they won't do a bronch. But see, mind it, in 1 month follow-up, if they are doing a spirometry, and mostly till 3 months, there will be a restrictive pattern in spirometry. But if they find it that it is a obstructive pattern, then they will do a bronchoscopy to see if there is something happening in anastomosis. or on routine follow-up with CT scan. If there is some ACR-like reaction, then they would do a bronchoscopy. Otherwise, they will follow their own protocol. That is 14th day, 1 month, 3 months, 6 months, and 12 months.
Yeah. Dr. Belal, like, how do you suggest, like, from your experience, like, bronch immediately after transplant? Because some centers do daily bronchs till the patient gets extubated. So you're on mute.
So I don't think we do a daily bronchs, as Gaurav pointed out. Most of our patients, we look at the X-ray, we look at the ventilator parameters, and if everything seems to be going good, we don't intervene. But yes, if there is, requirement for secretion evacuation or there is any evidence of requirement of a bronchoscopy, so we do it in that. Otherwise, we routinely do it at 2 weeks.
Yeah, I think that's the best way to, because like minimal intervention for the patients, and like rather than insulting the anastomosis, I think if you protect the anastomosis, then the day census and everything will be less after the transplant. Yeah, so that's a great start. So now regarding the graft assessment, ECMO and early complications. So initially we just started our immunosuppression, we started our antimicrobial prophylaxis. We had a decision regarding our bronch, whether to do. We have our hemodynamic settings and goals and everything. So the patient is going on well. Then now, how do you, Dr. Soumitra, how do you assess the graft immediately after transplant? And like, when do you label it as primary graft dysfunction? So because down the lane we'll be having PFTs and everything after 3 months, or we'll do. But initially, first 1 week or so, what are the parameters which can say that okay, this graft is saved or so?
So, after implantation, the reperfusion in the theater, and then during the first few hours in the ICU, this assessment should start, and it will focus on 3 important things. 1, how is the gas exchange or the oxygenation is happening? Number 2, how is the radiographic picture? And number 3, how is the hemodynamic status? These are the things. So in oxygenation, we have to see the PF ratio, but that as per guideline, we have to have a 5 to 100% and a P of 5 or somewhere near to that. And then you must see the PF ratio. So I will talk about the PF ratio later. So this is one thing. And then you must see the chest X-ray, whether there is an infiltrate is happening or not, bilateral diffuse infiltrate. But remember that infiltrate does not always mean that this is a PGD. It can be due to a heart failure, pulmonary edema. It can be a pneumonia setting up. It can be a large pleural effusion causing some lung collapse, surgical complications. All those are possible things. So must exclude them. And then is the hemodynamic assessment. So the hemodynamic assessment, we must see how is the main important thing is the pulmonary artery pressure. As you know that when the graft is coming in, if you do not do a good perfusion before that, there will be always this high PA pressure will be going up, and then you must have to then connect it to the bypass shunts or an ECMO. So look very closely the PA pressures. If it is becoming high, you must ask the question why it is happening and manage it. And then there will be primary cardiac dysfunction is happening or not, fluid overload is happening or not. So these are the other things you must see before you decide that this is deep perfusion injury. So when do you do the assessment? As I said, as soon as at the very early stage is within up to 6 hours. That is called the as per ICCT guideline is T0. Then at 24 hours, 48 hours, 72 hours. And then you decide whether there is a PGD. PGD classification and grading, we all know, depends on 0, 1, 2, 3 grade. And that depends on PF ratio less than 200 or patient is on ECMO. Then that is PGD grade is 3. Less than 200. Between 200 to 300 is grade 2, and above 300 is grade 1. Grade 0, there is no PF problem, no infiltration. So this is how we evaluate whether the patient is having a PGD or not. So 3 important things: hemodynamics, oxygenation, and the chest X-ray infiltrates.
Yeah, thank you, Dr. Soumitra. What's the incidence of PGD at your center? Like because most of the percentages what we get in ISHLT are from the Western scenarios. Like, what are the incidence of? Because yours is one of the first center to start all the transplants, and so what's the incidence of PGD at your center? Frequently you see PGD.
Moderate grade, I will say somewhere about 30% of the patient gets a mild to moderate kind of thing. Severe, very rare. Somewhere about say less than 5%, or 5% kind of patients will get severe PGD, where we need to prolong the ECMO and then slowly come out. But the one important thing is just continue to give the support. PGD, most of the time, if you have a good support program with a ventilator or with an ECMO, most of the time PGDs will slowly get better. If you don't, you are in a good big soup, and perhaps later on glad. But yeah.
Yeah. Thank you. And Dr. Gaurav, like as Dr. Soumitra mentioned that with good ventilator support and good balance, fluid balance and everything. So what steps you take for the management of PGD in terms of ventilator optimization, in terms of fluid management, in terms of like what are the other drugs which you give for PGD?
So, sir has already given half of my answer that better volume, like a normal volumic or slightly negative balance should be kept, and protective ventilator strategies like ARDS should be kept in. Then another thing which I would like to add is that in Western countries they are using inhaled nitric oxide or epoprostenol in such type of patients, and they have find a good effect of that. And secondly, ECMO also, like we can continue the ECMO, or if a patient has already been extubated, then they can be reintubated and kept on ECMO in such kind of patient, and then later on they can be weaned off.
So, Dr. Soumitra, inhaled nitric oxide, like how do you think is the benefits of inhaled nitric oxide and PGD?
During the early stages, as in all Western countries, but how much is the benefit? I perhaps keep my fingers crossed. Maybe it's not a very politically correct answer, but I have my own reservations how much it really works. Theoretically, yes, it must work. It should work. It's a fantastic one. But in actuality, I have my own reservations.
Yeah, I think like fluid balance and ventilator optimization and like identifying the alternate causes and everything, I think we can get away with PGD most of the times. And with in extension to that, Dr. Shyam, like how do you like most of the times the surgeons prefer to decannulate the patients on table like after the surgery itself, like after transplant. Most of if it goes on really well, if it's a patient who gets admitted into the hospital only for the transplant from the OP basis, and a lot of times we can decannulate the patient immediately after the surgery. What are the scenarios where we have to continue ECMO, and what are the scenarios where we have to restart ECMO after decannulation?
You're talking to me. You're asking this question to me,
no,
or
Dr.
somebody?
Shyam Krishnan, Dr. Shyam.
Shyam.
So I feel most patients, if the surgery is done well, they tend to do well, and you don't need to basically put them on ECMO. But one thing which we knew, we actually look for the graft compliance and the resolution of if there's a primary graft dysfunction. So while weaning off ECMO, our usual, the decision basically hinges on the radiographic clearance, the PF ratio, and acceptable compliance on the ventilator. So if the patient is on a VV ECMO, and if the sweep of trial is good, and the patient is maintaining appropriate pH, good pH on ABGs and a saturation, decent saturations, and is maintaining it for 4 to 6 hours, then we can decide to decannulate. And in the case, if it's a VA ECMO, sorry, then you need to see vein flows down to 1 to 1.5 liter per minute of the flow. We confirm the cardiac recovery, and obviously you use the TE to monitor the RV. And if the RV can handle the preload without any circuit support, then we can take a decision to decannulate or wean off from the VA ECMO. So the rule is that we need to ensure graft compliance and see if the PGD is resolved or not. So that's where the decision hinges.
Dr. Belal, your inputs on like when are you comfortable to decannulate these patients? Are you comfortable to decannulate in the OT, or like you'll wait for a day or so, or how do you do in your regular practice?
Can you hear me?
Yes.
Sorry, there was a network break. Could you repeat the question, please?
No, I just wanted to know your experience because the surgeons are the decision makers at the time of decannulation of ECMO. So when are you comfortable in decannulating? Is it at the time of once you're done with the transplant, if you're comfortable with all the parameters, you're comfortable in decannulating in the OT, or wait for a day or two and then decannulate?
Try and complete on the table wherever possible. So if all the parameters, fall into the right checkpoints, then refer to decannulate and ECMO on table.
Okay. Dr. Mallikarjun, so these patients, all of these patients, we need good respiratory drive for them to come out of the ventilator, but there'll be an extreme pain because of the clamshell incision, right? So at some point we have to balance the sedation, the pain control, and their respiratory drive. So how do you balance these two, the drive along with the sedation, and how those help in weaning from the ventilator?
Good analgesia is very important, madam. As if we don't give adequate analgesia, there will be splinting of the chest and retention of secretions. In fact, leading to the anastomotic problems, suture issues. Along with that, we have to give proper sedation or mild sedation so that we don't give a deep sedation. Otherwise, weaning from ventilator becomes difficult. So thoracic epidural analgesia is preferred, and we have to give NSAIDs and look for any contraindications where it can be given or not given. And in sedation, the sedation should be such that we take off the opioids and fentanyl infusions earlier, and which is minimal sedation and easily arousable like dexmedetomidine. So that weaning will be easier.
Yeah, recently hearing a lot about cryoanalgesia. I think the Stanford guys, like University of Stanford people, they're using a lot of cryoanalgesia. They'll block those segments where in those one to two segments up and down, they'll block the nerves with this with a cryo probe, so that they won't require much of sedation or much of analgesia or anesthesia or anything post-operatively, not much paralytic agent, not much sedation. So any take on that, like any one of you are using cryoanalgesia at your center? It's becoming very popular these days. So any of your centers are using cryoanalgesia? I just wanted to know your inputs. Dr. Belal, any idea or what is your take on cryoanalgesia? How effective do you think it is?
Point when we do practice vomiting, there's now a very good evidence that cryoanalgesia, and because these practice patients have a lot of bar placement and have long-term pain, it leads to excellent analgesia. Unfortunately, at our center, we've not been able to use it right as of now. But it is a very promising method of controlling anesthesia because it gives a sustained analgesia for a prolonged period of time and can reduce the anesthetic requirements and make the patient breathe much better. So, although we haven't been able to try it.
Yeah, because they have excellent, Dr. Jaslin, she came for the INSHL recently. The studies were showing that they extubated a bit earlier. The patients participated in rehab a bit sooner, physio and everything, because there's no pain for it. It is lasting for approximately 10 days or so. So I think that's an effective tool. What you need to.
When we look at the data from practice direction, because the bar placement, particularly when they cross in the elder age group, they have a lot of pain. And when you give cryoanesthesia, there have been reports that suggest that more than 2 weeks in some cases have been, good anesthesia have been able to be achieved. So I think it's a very good and promising, although we have no experience, we haven't tried it.
Yeah. I think we should start exploring that option of pain control so that sedation can come down, the patients can cough out easily, secretions can come out, airway anastomosis challenges will reduce. So I think hopefully we'll see most of these changes in our practices also. So now, like our patient is under good immunosuppression, they are having on good antimicrobial prophylaxis. We have weaned them off ECMO and everything. So most of the centers, I think, will discharge by 2 weeks, right? Like so, if the patient is well enough, first for 5 to 6 days in ICU, and then in the ward once the chest drains are removed and everything, and we'll discharge these patients. Dr. Belal, like after discharge, because we all know we are all pulmonologists, we know what medically we have to teach these patients, what all we need to understand. But from surgical point of view, so what all you want, you expect for your patients to do after the transplant, and what the patient should monitor regarding their wound and other things from your end, like. So you're on mute.
Sorry. From, of course, as pulmonologists, I mean, we always thought that surgeons usually are a part in the assembly line. Once they put on the engine, most of the work goes back to the service engineers, which are the pulmonologists. So, in our perspective, when we look at these things, so a couple of things that we look at is one is chest wall instability. So we do ask the patient about any clicking sound. So we do tell them that if they're feeling any clicking sound while they're breathing. Also to look at the wounds very carefully, if there is any discharge, any swelling coming from particular area. Sometimes it's seen, there are pockets of collection being formed, even like around 3 weeks after surgery. So, we need to really identify them soon, because these small pockets of collection, be it, fat necrosis, can very easily turn into an infected collection. So we do tell them that if they observe any swelling, redness, or unusual bulge, they should report immediately to us. So, and the other thing that we, look at is any new onset breathing difficulty, which is not there. So that could indicate, development of the region or pneumothorax. So that way, that also we, sort of check. Then, of course, the pulmonologist is checking the ventilative plan. So by and large, when you look at surgical standpoint of view, so we do tell them that if they're facing any new sound, stridor-like thing while breathing, so they should report to us. There is new onset breathlessness. There is any, surgical instability of the wound. And of course, some patients have difficulty in coughing or taking deep breaths, and could be an indicator of, phrenic nerve dysfunction also. So these are the parameters that we ask them to look at, apart from the medical parameters that you're already looking at.
Yeah, like we have seen few patients with phrenic nerve palsy and presenting with breathing difficulty, elevated diaphragm. So, what are the scenarios where you feel that when the chest wall is thick, is it because of pre-existing additions, or like how do these people develop phrenic nerve palsy?
So when you talk about phrenic nerve palsy, most of the phrenic nerve palsy that happens during lung transplant is when the additional is. And on the mediastinal pleural part, when you're doing the additional is, you might injure the nerves. So majority of the times, because we're very conscious of the fact that you want to preserve the phrenic nerve, you try and preserve it as much as you can. So we, in our hospital, we technically try to, delineate the whole course of the nerve. But despite that, because of the addition, sometimes it may get stretched. And even if it is not a transaction, it may have, neuropraxia and all this stuff. So most of these patients, you will be able to figure out immediately in the post-operative X-ray when you will see an elevated diaphragm. And when we look at that, we already know that, there's some phrenic dysfunction. And these patients might have issues because they ipsilateral lung will have difficulty in clearing secretions, but majority of the times, if it's only a neuropraxia, it will eventually, recover. So, for example, when you in the past, for when you do lobectomies, they used to crush the phrenic nerve to obliterate the space problem. And when you look at that experience in due course of time, over a period of 4 to 6 weeks, the nerve function will recover and improve. So these patients are then requiring more physiotherapy, more intensive training with coughing and all. So you asked, this is my experience. So you have to wait for it to resolve over a period of time. So, but there is a problem. But if you have identified that you have injured the phrenic nerve by actually transecting it during the surgery, and it sometimes may happen, then we would recommend placating the diaphragm in the same setting so that the patient does not have that problem. Otherwise, most of these cases will wait for 6 to 9 months. Slow recovery will happen most of the cases if it's not a complete transaction. But if it is not improved after 6 months, then you should consider some sort of.
Okay, so if we see that, like, we'll be definitely knowing, right? Like in the surgery, that whether we have transited the
Yeah, you should be able to see, because our experience in robotic thymectomies and for thymic tumors, when we are doing it, the very next day, if you have injured the nerve or there is a nerve damage, the very next day you can see the elevated diaphragm. So in most cases, we'll be able to figure out.
So we can wait for up to 6 months, like even if the diaphragm is
Yes.
elevated, we can
So
wait
if the surgeon is very sure that he is not injured, so like I said, if you have been able to delineate the whole course of the nerve during the surgery, and you're very sure that you've not transected the nerve, then of course, wait and watch the best way out. But if you're already sure that it has been cut, you would have plicated it during the surgery itself.
Okay, so like after 6 months or so, if it is not, if we are not able to restore the function, then we have to do a diaphragmatic plication at that point of time. And during these 6 months, because few of the patients, like even with despite regular physio and coughing techniques and everything, they still feel breathless. And do you think we should give NIV or CPAP or BiPAP, because the anastomoses are very fresh? And how do you manage this in the early first 3 months period also?
In initial period, it's very difficult. It's a double-edged sword. You're giving a positive pressure in an already, sort of a compromised vascular anastomosis. Then it becomes difficult. But, you have to, titrate your requirements. If the patient is really, struggling with breathlessness, and in the night time, you want to give an IV at a very low pressure so that he's maintaining, then it's okay. But at least wait for at least 3 to 4 weeks so that at least some anastomosic healing has started. Very early period, it's quite difficult, but if it is required, then, of course, it has to be done.
Yeah. Thank you. Dr. Gaurav? Yeah, Dr. Soumitra.
Well, have you ever tried anything other than the surgical route, like say something for the stimulating the diaphragm, those kind of devices?
There is, you're talking about phrenic nerves pacing, sir.
Yeah.
We haven't tried it, sir. We haven't tried it.
Do you know anywhere in India anybody does it?
I think we tried to find out for a couple of patients where the spinal injury patients come to us with these problems. But I don't think that phrenic nerve pacing equipment is available. It's not available.
Thank you.
Dr. Gaurav, we have, after discharging these patients, when we ask them to come for a follow-up, so when do you prefer the first follow-up visit? Like few centers will ask them to come on 3 days, few centers will become. So when do you ask for them first follow-up, and what all investigations, the basic investigations you ask them to get back with?
So, ma'am, after discharge, depending on discharge, if it patient on discharge on 20 or 25th day, obviously, then on 1 month protocol, whatever we are following up, we will follow up. But if a patient is discharged early, then definitely we have to monitor the drug levels of immunosuppressants. And mostly the CBC, we have to titrate the dose of anti-proliferative drugs. So we have to keep, the European countries followed lymphocyte count, and that is 0.5 to 1.5 into 10 raised to power 9 per liter. And according to that, they titrate the dose of the drug. So CBC is most important, and after that, along with that, drug levels. And obviously, in the initial phase, there is a chance of risk of infection. So if the patient was CMV negative, the recipient and the donor was CMV positive, they have to do quantification of CMV DNA and look for ACRs if you find any symptom in patients.
So when do you get your first PFT done? Like if you discharge the 2 weeks of time.
The 1 month time is means after 14 days, means if the patient is discharged 14 day or 28 day, then first 1 month is the ideal time when we can do a spirometry and we can see, because lung function start improving after 3 months generally, and they keep on increasing up till 1 year. And the 1 year is the time when we say that it's a baseline lung allograft dysfunction or not. So means the most important is from 1 month, 3 months, 6 months, and 12 months. These PFTs will decide that patient is having baseline allograft dysfunction or they are doing good with the allograft.
Yeah, I think first visit, I think we can even ask the chest X-ray along with the investigations, complete metabolic panel, like hemogram and everything, along with the this thing. But the DSAs, I think after first month only we'll ask the DSA if the patient gets discharged early. So when we are Dr. Shyam, so when in the 3 months, like, so first 3 months anyway, first weekly, we'll ask them to come immediately after the discharge, and then once in 15 days, and then 3 months. So at 3 months, what all investigations do you do? So because a lot of stability occurs at the time of 3 months. So like initial 2 weeks or 1 month, they'll be having pain, they're getting enrolled into rehab, the travel from their native place, all these things. But at the end of 3 months, they'll receive some stability. And what all investigations do you think? Like, because from that point of time, I think the people will start going to their own native places. They'll come back from there. Few prefer to get investigations done. Few follow up with their own previous doctors. So what do you think? What all investigations we have to do at 3rd month mark?
So I feel that is the time when obviously a surveillance bronchoscopy needs to be done. Look, you do a spirometry to see if the the lung function is improving. Look at the levels of the TAC levels, the level of immunosuppression, and then obviously monitor for the patient's any other concern which the patient has. So I feel that is the time. Usually, you assess for that is when you start to see some kind of a stenosis appearing. Before the initial first 1 to 2 months, yeah, you would think of ischemia or a graft or stump dehiscence. But usually 3 to 4 months, you would see some kind of, if at all a stenosis happening, you can see, you start to see it that time. So you monitor for that. You'll screen for infections, take a lavage, monitor for infections, and obviously level of immunosuppressions and spirometry.
Yeah, like say most of the centers say that the 3rd month PFT is an indicator of the long-term function of a graft as such. So even my research was like that, the combination of PFT and impulse oscillometry at 3rd month in predicting long-term development of clad. So I think by 3rd month, because there is a stability, I think home monitoring of spirometry till that time, and 3rd month a proper lab PFT is, I think, very good indicator of the graft function as such. And apart from all the investigations, what Dr. Shyam has mentioned, Dr. Soumitra, so where do you place the GI investigations? Because that the gastric GRD or all these are the most common reason for the development of clad universally, like everyone has agreed now. So how do you monitor regarding GRD, or like when do you have any biomarkers in the bowel you do at 3rd month to assess these the risk of developing GRD or development, like what all tests you do at 3rd month regarding gastric issues?
ERD, as I talked in
We are not able to hear Dr. Soumitra. I think the volume is lower.
you can hear me now?
Yes, yes.
Yeah. So, as I said, that the uncontrolled reflux and aspiration are the most major modifiable and easily modifiable cause which is causing the graft dysfunction. And for chronic rejection, clad, we just talked about in my talk also about this. It is very important that around 3 months we must look after the GI thing, what's happening. We have done it during the pre-transplant evaluation always. But in the post-transplant, perhaps even when there is no symptoms of any GERD, specifically if there is a known GERD, is a known connective tissue disease like say a scleroderma patient, or if there is a known delayed gastric emptying happening, prior aspiration concerns during the first 1 month kind of thing. So we must do GI monitoring with the pH and impedance monitor, upper GI endoscopy, or an esophageal manometric gastric emptying studies, and see how things are going. These are the most important tests at that time to do. It can be done earlier or maybe repeated if there is a reflux symptom. But remember that don't always focus on reflux symptoms. Most of the time, actually, as per papers, 40 to 50% of the time it can be asymptomatic reflux. So a regular 3 months follow-up, and then at around 9 months or 1 year follow-up of a upper GI endoscopy, and all these GI emptying studies is very important to find out what is happening. Our drugs, what we are giving, immunosuppressants, are also causing delayed gastric emptying. So these are important tests at that time.
Yeah, totally agree. Like 24-hour pH monitoring, impedance studies, and gastric emptying studies are very important at third month mark, because like if we identify them early, and if we refer to surgeons for some plication or some poem, then I think a lot of issues will be settled.
As I talked to the fundoplication, if your prokinetics and your gastric acid treatment kind of thing, drugs are not helping your symptoms of GERD, or your investigation shows that the GERD and the pH balance is not correct, then perhaps the sweet spot is doing the fundoplication surgery is third month. It can be done even earlier if our surgeons are go ahead with that, then it can be done earlier. But 3 months must be, we must take call on GERD.
What's your take on this large airway when we do a bronchoscopy at third month, when we do a bronchial wash? So there are certain areas we do, right? Like large airway bronchial wash and the right middle lobar, like whatever a segmental ball will collect. And a lot of studies are now on like bile acids in large airways predicting the development of clad and everything. So are we following any biomarkers in the ball to predict this reflux or anything? As of now, I don't think, right? In India, we are still not checking for any.
Yet come from bench to yet practice. They are still in the bench.
Yeah. Okay. So, like, apart from medications, monitoring, and everything, one more important thing which plays a major role for success of these patients is early rehab and physio. Dr. Mallikarjun, so how do you think when these patients after transplant, they'll be having so much, or they'll be in so much of pain, they'll say that we are not ready for rehab or physio or whatever. So, when do you think that's the ideal time to start the rehab for this patient or physiotherapy, and what are the key rehab strategies or plan? And apart from this, there are a lot of food interactions with the immunosuppressants also. So we have to, at the time of discharge for these patients, we have to restrict certain foods and we have to avoid certain exposures. So how do you suggest physio and food and the entire rehab plan? How do you strategize for your patients?
Early rehabilitation is important, madam, because post extubation in first 12 to 24 hours, first passive limb movements along with assisted active limb movements, and making patient to roll and sit in the bed, then at the edge of the bed, then from bed to chair, and afterwards assisting patient for the standing. So in this way, we progress over a period of 4 to 5 days. We make him do gait training. The importance here is we should look that there is no hypoxia, dizziness while we do rehabilitation aggressively. So we may have a hemodynamic instability also. So with adequate analgesia, the progressive rehabilitation is done from sitting to movements. This will help in to avoid the secretion retention and early graft functioning or graft healing also, so that if we mobilize early. And then we have to do aerobic training like increasing the walking duration and sitting to stand step ups, so that there is resistance training of lower limb, followed by a long term. There should be a supervised or some feedback over a period of 6 to 12 months of rehabilitation happening if they are far away. And coming to the food, there has to be precautions taken in the form of avoiding any raw uncooked meat or partially cooked, eating street cut fruits or any raw salads. It has to be home cooked, and strict hygiene, hand washing before every meal, and home cooked hot foods should be served. The regarding interactions, potassium potassium increasing foods should be avoided, and pomegranate and grape juice, which can increase the tacrolimus levels, should be advised.
Yeah, totally agree, because these patients will start moving to their places, and even the doctors over there or the patient's family and everyone should know like what to eat and what not to eat. I totally agree, like to avoid all the raw kind of foods. And most commonly, what do we see that these patients develop some kind of diarrhea. And if you rule out CMV, lot of, if we refer to a gastro, they'll add probiotics. But I think we should even avoid probiotics early post-operative period because they may develop into significant infections also. So avoidance of probiotics, curd I think is acceptable, but the high concentration of probiotic capsules or powders or liquid should be avoided after the transplant, I guess. So I think we are now like the first 3 months of transplant is done and like the patients are doing really well. Then the long-term management till 1 year, which is very crucial in predicting the long-term outcome. So by first 3 months, the most common rejection if the patient develops, we'll see it as acute cellular rejection and then slowly starts developing AMR or start developing infections, and all these insults will result in the development of CLAD. So, Dr. Belal, just wanted to ask, like, during the first year after this transplant, so why do you think, like, if the patient had no surgical complications in initial first 3 months, then do you think you'll have to see the patient at any time after this time, or like, have you any indications why they have to visit a surgeon over the long run?
If the first 3 months have passed on quite uneventfully, the chances that this be required reduces, but not goes to zero. Because, in the late part also, we've seen that airway complications can develop, and which is probably one of the things that we need to look at on a regular basis. So one of the complications, and then there could be some problems with chronic space problems. So what we've seen sometimes after 3 months, patients who've had recurrent effusions that have been drained multiple times, they do develop what is known as a non-expanding lung or an entrapped lung. In those situations, as a surgeon, we may be required. And there could be chest wall deformities that can happen at a later stage also. So the problem with, particularly with clamshell incisions where you're cutting the sternum from in the horizontal aspect, most of the time they're closing it with a sternal wire. And although the sternal wire sort of fixes, but it doesn't really prevent the sliding movement, and therefore there can be non-human related issues. In later part, also some of the patients may have the giveaway of the intercostal muscles, and there may be lung herniation and deformities there. So these are the things that and of course, the last but not least we've already discussed about is the diaphragmatic dysfunction. So we can have diaphragmatic dysfunction which is persisting beyond 3 months, and which we need to look at as surgeons.
Yeah, even in Toronto, they do a lot of late transplants. A lot of people, they do transplant after 60s, 70s, and even 80s also, they do transplants. And they are seeing a lot of the sternal dehiscence, like it is getting crackled. And now I think apart from sternal wise, they are doing a plating also to prevent this, because of late they are seeing a lot of dehiscence, like, so they are doing a plating and then wiring. So will that really help in these patients?
It makes a lot of sense, when you talk, because when I look at the mechanics of sternal wiring now, so you're putting it across the transected sternum, but it doesn't really fix this movements to that extent. What it does is it approximates both the ends together, but it doesn't really fix it very nicely. And that is probably the reason for, and these patients, many of them are debilitated, and God forbid if they develop infection, the overriding becomes very common. So the plating is a very, very good option, and a lot of centers, as you very rightly said, have started doing that they per primum plating it. But in our center, we have not done that. We do have this, fear of that it's an additional foreign body, and if it gets infected, so we have had incidences where we did it for trauma and then got infected, and once it gets infected, it becomes a very difficult task to follow it. So we haven't done it, but yes, definitely, that's one of the solutions to avoid this problem for sternal non-union and override.
Yeah, I think, but because we are doing slightly less elder population compared to the Western people, I think it's still, I think, not a major problem for us. But I think this is an alternate option if we develop anything. So, Dr. Gaurav, like, how do you monitor infections? I think infections have been discussed in the previous topics.
Yes.
But key warning signs, like these two are again, infection versus rejection is always a dilemma. So what are the and because these patients are on immunosuppressants, the TLCs may not be elevated or so. So what are the key warning signs? What do you say? Tell the patients when you, after 3 months, when you are sending the patients off, like what are the clinical parameters or signs they have to identify and report to us?
So, like, if a patient means if a patient have cough, they have purulent expectoration, or they have like lethargy, even if they develop nausea, vomiting, diarrhea, they have some severe headaches, then all these signs, shows us that might be some sort of infection which patient is facing, and we should send viral marker, fungal markers, and CBC and CRP should be done. So if a patient has any such type of symptoms which is not normally he or she is facing, then they should be thoroughly investigated. And obviously, as I said, that we should keep a low threshold, as and when patient comes with this symptom, we should follow up with the investigation like X-ray or CT scan if required, and if required, we should send the sample like bronchial lavage for checking out the infections.
Yeah, I think we have to be extremely careful in identifying even the single complications. It's like post-transplant rather than pulmonology. It becomes more like a physician monitoring all these things as such. Yeah, yeah. And Dr. Shyam, see, apart from infections, monitoring of their antibodies is very important. So, how frequently do you monitor these donor-specific antibodies? And apart from that, and where do you place cell-free DNA in? And if the DSS are rising but the patient is stable, how do you assess both clinically and DSA wise the graft function, and when do you intervene?
So usually the protocol, it's like 13612. You usually assess for the donor specific, the DSA in those times. And if we notice a rising trend, so that is when I think so it triggers, the need for doing a transbronchial biopsy. And if that confirms a rejection, by histology, so then we need to, I think so, initiate treatment with IVIG, plasmapheresis, and potentially adding, rituximab if it does there. If it's just a isolated DSA, we probably we need not treat it aggressively, but then we'll optimize the TAC levels and obviously keep the patient under close monitoring, do more frequent spirometry, and obviously and serological monitoring. So that would be my way of assessing these patients.
Yeah, I think I agree. Like, see, rather than just treating the patients based on DSAs, I think we have to correlate that with the PFTs, the radiological correlation, and along with the transbronchial lung biopsies. And we base, even if the MFS are high, I think if they are stable clinically and radiologically and PFT wise, I think we can still wait till and keep monitoring these patients. And Dr. Soumitra, what are the early indicators of development of CLAD? Radiological and clinical criteria or PFT likewise, so when do you start thinking of CLAD in these patients in the first year of transplant? You're on mute, Dr. Soumitra.
So before we go into it, perhaps I would like to contradict slightly what Shyam said. I would perhaps like to treat even in a case of a high DSA if the MFI is more than 5,000, or in Indian circumstances if it is more than 1,000 perhaps. I would like to treat it because as I told in my talk that they are actually harbinger of CLAD later on. Even if at this time the patient does not have any symptoms, but perhaps a persistent DSAs, high DSAs, even in an asymptomatic person, perhaps better to treat. Okay, so as you are talking of the CLAD.
Just a second. So with rising, like first year, we target usually higher immunosuppression, right? And with higher immunosuppression and the risk of infection. So if the diseases are rising, I think we can increase the tacrolimus level a bit high and MMF a bit high rather than directly targeting with IVIG, plex or so.
Yes. Treatment means I'm not talking of going to IVIG kind of thing. Treatment means target higher immunosuppressants, increase the dose of steroids. We in India, we come down on steroid doses very rapidly and very quickly. Perhaps that we can have. I'm talking of only that. I'm not talking of a drastic measurements.
Yeah, okay.
So the CLAD is, we talked about that just so long, but still in a small nutshell, persistent, more than 3 months of decline in lung function. After 3 months of transplant, it need not to be after 1 year, even after 3 months of that, it can have a semi-urgent kind of CLAD also. And it has to be a more than 20% decline of the FEV1 from the baseline. How do you manage baseline? How do you go to baseline? three best FEV1 prior to that, and the mean of that is the baseline. And from there, if there is a more than 20% decline for that, which is persistent for more than 3 months, we say that this is CLAD after 3 months after transplant. So, but before going into that, you must exclude the reversible causes. That's very much important. I talked in that also previously. Exclude infections, bacterial, viral, fungus, ACR, AMR, large airway stenosis, cardiogenic pulmonary edema, pleural effusion, lung collapse, pulmonary embolism, single lung transplant. All these mechanical things has to be, pulmonary embolism has to be taken care of and exclude. Now you said how to differentiate between BOS and RAS. That's okay. BOS is like our PFT wise obstructive airway disease. RAS is restrictive airway disease. Exactly the same as per our PFT definition. If VC will be less than 0.7 in BOS, in RAS it will be either normal or higher. FEV1 will be reduced by 20% as per definition for both BOS and RAS, but in RAS there has to be more than 10% decline of the lung function, the lung volume also. And then the radiological picture, the first thing is air trapping in BOS, the obstructive airway disease picture. There will be air trapping best in the expiratory city. Also, there can be mosaic attenuation, bronchiectasis in the late phase. There can be hyperinflation. These will be seen in the BOS, whereas in RAS, there will be upper lobe infiltrations, upper lobe fibrotic changes. There will be pleural involvement. So, pleuroparenchymal fibroelastosis is the typical pathological changes later on. So, there can be associated GGO, there can be associated bronchial consolidations kind of changes. There can be some volume loss also. So, restrictive changes, obstructive changes. That's how we can do it.
So, Dr. Mallikarjun, because like we have only few centers for lung transplantation as of now in India, and I think entire North India, we don't have many centers. So, if we do a transplant for a patient from North India and we are monitoring him here, we cannot ask them to come every 2 weeks with a spirometer and everything. So, how do you suggest, like, what is the role of home spirometer you think, and how frequently patient has to send us the value so that if we identify them early, then we can start like working on them aggressively so that to prevent all these things.
So in Bangalore, madam, what I know is they do WhatsApp-based communication, and they do it daily and send it initially for 2 months. And but before that, the training the patient to do is very important. Sometimes they may not do incorrectly, and they may not do at the correct time daily at the same timing and standing. We have to instruct them to do it and send the readings. If there is a drop gradually, then it is an early sign of some complication happening. We have to take action. We will be aware of what is happening with patient. As you already mentioned, it is very important to correlate with the symptoms and what is happening with the drug level, so that we have an idea if there are cough, fever, we may have some clinical idea it is infection. Or so if there is a sudden drop more than 10%, then we may be having acute rejection. So in this way, we can monitor it.
Yeah, I think like as you said, like, monitoring of parameter is very important and proper teaching for the patients. And I think transplant coordinators play a major role here to send us the PFT values every day in the first 2 to 3 months, and then weekly once, followed by 15 months in 15 days. And a lot of times after a certain time, they feel that their lung function is good after first year, especially, and they'll forget doing even the regular spirometry or home spirometry. But I think at least we have to make sure that at least they'll send us once in a month as home spirometry reading so that we can identify it early. And Dr. Belal, like after first year of transplant, during down the lane, so I think what scenarios that you see your patients back again?
After first year, patient would typically return to a surgeon with complication. Usually more commonly, if there is any complications, persisting or a new onset diaphragmatic dysfunction, or there is any, sort of fluid collections, and some of them, converting into an entrapped lung. So in our experience, we've done one decortication in a post transplanted lung. And then chest wall related issues, as I told earlier. So these could develop herniation or osteomyelitis or, even a non-union. So usually after 1 year, no, these are it's basically problem driven, and usually most of things are handled by the pulmonology team, but the mechanical issues related to that we can address, come to us.
Any role of bronchial reconstruction surgeries in cases of refractory stenosis, or what do you think we should manage these refractory cases?
And option with majority of the times that the tissue itself will not be good enough for any kind of repair, and so mostly by and large we rely on surgical methods, because if we are to go in, usually the prognosis and the outcomes are not good.
Yeah, I think like 3 years or 4 years down the line, if they develop RAS or CLAD, then for a retransplant, they may come to you.
Yeah. That is something that we have to keep in mind when we're doing the transplant, particularly for younger individuals who have a longer life expectancy. And, many of them, as Dr. Soumitra said, once they develop plaque, which is not amenable to anything else, then you have to consider retransplant. So there, the mindset has to change for all of us, during the primary surgery, because we have to take care during the surgery that, this patient could be a possible patient for a future retransplant. So, when you're cutting the bronchial length, you have to, very wisely adjust the length so that later, if a retransplant is required, you can really help the patient. But if you really cut at the carina in the first surgery itself, and then it becomes very difficult to carry it out. So, I think the important point is, although we do not have any experience in retransplantation, but I think the mindset and in the future, going towards that direction, particularly for younger individuals who will probably need retransplantation in some of the methods.
Yeah, like I think, yes, that's a great insight. I think a surgeon should have that in future. If these patients go for retransplant, they should have a good surgical place to do the anastomosis and everything. I think that's a great point, Dr. Belal. So, all of you, like, because it's already hearing 10. So, what are the challenges? Everyone can answer from your end. Like one, I think if we can start with Dr. Soumitra, what are the challenges what we are facing in India in long-term care of these patients, and cost and logistics? What are the challenges what you're facing regularly?
The first challenge is the cost. Cost is the most important problem areas, which the patients treatment wise, after they get slightly better, say about 3 months or 6 months, or even after 1 year down the line, people who are of middle income group also is feeling the pinch of multiple bronchoscopies, and then after the treatment cost, and then perhaps if there is a rejection or treatment towards that, all these are a big drain. We talk about, say, about 30 lakhs kind of thing, or 35 lakhs is the package for transplant. But by the end of a year, I believe almost every patient is paying about 1 crore or kind of thing already. So that's a huge drain and a huge cost, I think. That's other than that, the infections is a challenge in India. Mainly the indolent infections, the fungal and the TB are a big challenge. The NTM are a challenge. Also the rejections. The rejections, acute, chronic, CLAD perhaps comes much later into picture, but the acute, chronic are the more acute rejections, either ACR or kind of a AMR. These are the bigger challenges. ACR is much more difficult, sometimes AMR also. And at the beginning, the challenge of how do you manage this reperfusion kind of problem. The PGD is another challenge for we the clinicians. Again, the problem area is we don't have a good HLA lab. Perhaps that's also is an important challenge where we can further progress. the patient selections, again, perhaps in India, the as we all work in a private setup, some kind of hospital's pressure or towards money making comes into picture. So somehow it gets clouded. Our best judgment gets somehow get clouded with that. Perhaps these are the most important problem areas we are having.
Yeah, Dr. Gaurav, how do you think we can cut down the cost by collaborating with the referral physicians so that they can do certain investigations and follow up with us? Or how do you think, like one statement from your end, like how do you cut down the cost for these patients?
Yeah, cutting down the costs will hardly matter because the 30 and 35 lakh or maybe 60 to 65 lakh is not a huge difference. Means maybe 5 lakh plus minus. The problem is, I would put it this way: like in UK, in Europe, it was all free for patients, transplant as well as post transplant follow up throughout the life. So obviously, that is the reason the center which I went, they have done 1500 plus transplants. But I will keep it this way: there are three types of patient. My three patients have done under lung transplant. One patient, that patient, she is very rich, and but post, and she was CO post bilateral bronchiectasis and COPD patient. She after transplant, because she money doesn't matter for her, and she spent around 1 lakh, but she developed renal amyloidosis, as I said. But she is also a very obese. Means now post transplant she have gained around, even after doing, means removing a whole lot of water from her body, she have gained around 10 to 15 kgs of weight. So even after a lot of push, she is not doing exercises. She is not worried about her health. One type of patient is this. Second type of patient, he is a chef and he was having end stage ILD, and he was transplanted. And after transplant, he learned that how he need to, means because he was a law, means he was some sort of money with him. So he now tries to maintain his body. He do a lot of workout. He have lost around 10 kgs of weight. He is doing very good. And but the thing which is that he can't leave his profession because that is the only earning point of view source for him. And that is where we tell him that you cover your face with mask, and you continue with your job. And the third patient, she is a doctor and she is 8 years plus post transplant. So she is smarter, she don't have money issue, and she is taking care of her health. So that is why she haven't developed infections very frequently, and she that didn't went into ACR or clad or something like that. So you have to have a patient who is quite aware of his health. He have to be well thought of. There should be some good physiotherapy centers which we don't have, which is targeted just as we went to that pediatric pulmonary fellowship sort of thing last month, and we saw that physiotherapist was actually, she was very well trained in respiratory techniques. So that is where we are still lagging in a lot. And then last is, so smartness, money is the biggest problem. Yes, we can cut down, like if government can collaborate with the local people, means if this Ayushman can be extended to 5, 10, 15 lakhs, and something the government can give, something can NGO can cooperate, and some amount of money the patients can, because what you are telling about labs and the investigation which can be done at home, you need to understand that 90% of the periphery blood samples and the labs which they do, they are incorrect. Means even if they will come to you with those labs, you won't, means they will give you around 7 hemoglobin or 10,000 platelet, and they are bizarre. So you have to do labs at your center, which is, you means, you surely are, you are sure about that this will be the good labs. So
Dr.
there is
Belal,
no
yes.
monotonous type of thing that you can, like if it is Apollo group of labs, and even Apollo group of labs throughout the country won't give same results. If there are some smaller centers, those are just collection centers, there will be a lot of problem with hemolysis and every other thing in the sampling.
Yeah, Dr. Bilal, anyway, like we can cut down the cost from 35 lakhs down. I think most of the centers are having 35 lakhs. So can we cut down the initial surgical cost or like ECMO cost by using our own tubings or anything? Yeah, can you please unmute?
Do that, but we tried very hard. Um, but I think the bare minimum is what we have been able to achieve is around, as somebody pointed out, you can't really bring it down more than 2-3 lakh rupees, or maybe at max 5 lakh rupees. But we have tried very hard to do that, and at present we just stuck to 35.
Okay. Dr. Shyam, if you have to change one system, like something in India, like what do you think, like which will improve the logistics, cost, and long-term outcomes of the patients in our country?
So I feel sensitizing the primary consultant who refers, to kind of be proactive, introduce the idea of a transplant early on in the course of the
Yes,
disease.
agree.
I feel that, rather than, so most places we see that once the patient is very sick in the ICU, not making it, give them the option of the transplant at that time and say, this is the only thing that is left to save the patient. I think so that mindset needs to be changed. We should sensitize patients as well as, their primary care physicians as to introduce the concept of a transplant if indicated, at least, or get in touch with one of the transplant teams, because and from the patient's mindset also, I think so the moment you say transplant, they feel that this person is washing his hands of me type. So that is another, so we need to handle it in a very deft manner. We should have awareness programs. The government should take initiatives as to say that when your physician advises you, have a word with your transplant physician or the transplant team, know the pros and cons, what are the finances to expect. And here I feel we definitely need the government's support in some way or the other, or insurance companies should step in, because I know a lot of patients who keep, if they get, it's a matter of just one bug getting colonized. I know this patient who keeps getting, post transplant, she keeps coming. You give her nebulized antibiotics, and nebulized antibiotics are not cheap. She grew Klebsiella sensitive only to colistin. And, if you have to nebulize them for a month or 2 months, even that is pretty expensive for a middle class patient who just managed to cover the transplant costs. And getting admitted in a private center, be it his hometown, in an ICU for a pneumonia episode, easily incurs a cost of at least 3.5 to 4 lakhs. So, and that if the patient is, recurrent admissions are there, it definitely takes a toll on the finances, even if they could afford the transplant early on. So I feel there should be some kind of insurance program, some kind of governmental help to these patients. And obviously increasing awareness is one thing which I feel, will ensure good outcomes.
Dr. Mallikarjun, what's your take from your end? Like, what do you think will change this dramatically if there is some change in the system or in the government or in the, I think private hospitals have to step in. They have to provide, because they aren't really good with the transplants, and like if they step in and provide some discount for these patients whenever they come in, I think that's again a good thing. So from Dr. Mallikarjun, I want to hear from you before closing the session.
There should be standardized follow-up protocol, madam, across this thing, so that it is monitored appropriately. If there is a proper protocol, it will solve a lot of issues. As there is, the issues are arising because of follow-up only. So there should be some standardized protocol, I feel, so that it is easier, because wherever they go, if it is standardized, how for TB example, treatment is standardized. If the follow-up protocol is standardized, it can be managed at the local district levels till they get the attention or they come to the tertiary center.
Yeah, I think totally agree with all the inputs from you. Like first is early referral, because early referral patient will be a bit more healthier and less long-term complications. And second is like strict follow-up protocols. And I think like we have to develop a nationwide, at least not if we are not following the Western, because in India, I think we should develop a strict transplant protocols, like post-transplant follow-up protocols, which are uniform as such, because Now, as of now, there are few centers and every center follow its own thing. And when the referring physician sees, they'll be having a lot of confusion also. So we have to develop, I think, certain protocols, how to follow, what are the immunosuppression protocols, what are the antiviral, antibiotic prophylaxis. I think if you make it a bit uniform, like anyway, case-based, they'll differ based on the levels and everything, I think, but we have to bring some uniformity in these. And I agree, like the private insurance companies have to step in, even the corporate hospitals have to support these patients, and patient education and that awareness of the complications and early identification. And apart from that, rehab. So the early rehab and all these things, because they'll think that again it's costly. They have to pay again some 30 to 40,000 from their pocket after the transplant. So I think all these early in the period, if we initiate, I think then the long-term outcomes will be much better and we can give a really better quality of life. So I think we have crossed a lot of, like Soumitra has initially told me to cut down the schedule early, the session early, but I think it's 10:10 because the inputs are really very insightful and it got carried away. And thank you all the people who have joined the session. Thank you all for joining today on the session on lung transplant follow-up. We have discussed all the parameters of these topic, and our panelists have beautifully highlighted how follow-up is not just a routine checklist, but the continuation of the transplant itself. Like about a blend of vigilance, compassion, teamwork, and early intervention. So I think from now onwards, at least we will try to develop a uniform follow protocols, and we'll try to request the government to give some support even after the transplant, not at the time of transplant, because somehow if they manage the 35 lakhs down the lane also, it's becoming difficult for patients. So some government support and some insurance support, I think, have to be there. And thank you everyone, and I think good night, and we're logging out. Thank you.